Hey everyone, welcome back to my channel. Thank you so much for clicking on this video. If you're new to my channel, my name is Melissa and I'm a nursing student. So in my last video that was just uploaded, I talked about my experience in the didactic portion of maternal child nursing. For those of you all that have not seen my previous videos, then you may or may not know, I am a nursing student. I go to Chamberlain University and I attend their evening and weekend ABSN or accelerated BSN program. I just finished taking maternal child nursing or maternity, or for those of you all that are Chamberlain students, the course number is NR327. So I just finished that session of the class. And so I just uploaded a video talking about my experience in the lecture portion or the didactic portion of the class. So in this video, I'm just going to be talking about my experience in the clinical portion of the class. So since I'm in the evening and weekend program, I attend lectures on weeknights in the evenings because I do work full-time during the day. And then my clinical rotations are done on weekends. So this past session, I went to the hospital every Saturday for 12 hours on a maternity unit. So I want to start off by saying that this was an amazing clinical. I feel like I've been so blessed and so lucky with my clinical experiences so far because I've heard people have nightmare stories about going to the hospital, or even if they're not nightmare stories, they just don't have very enriching experiences. And I feel like most of my clinical rotations so far, knock on wood, have been either really unique or really special, and I've gotten to do a lot and see a lot. And so thankfully my maternity clinical was no different. I always say that I don't want to decide what specialty of nursing I want to go into officially until I'm pretty much in my last class or done with it. But as I'm getting closer to finishing, I'm now 6 months away from graduation, I do need to start thinking about what specialty I want to go into because I need to start applying to jobs in a few months and residencies in a few months. And so I will say I've narrowed it down to my top 3 specialties, and OB has officially become one. So I think I would love to be either a NICU nurse, a labor and delivery nurse, or a postpartum nurse. Like, my experience in this clinical was incredible and I just had the best time. I had an amazing clinical instructor and I loved it. The only thing I did not like about this clinical was how far the hospital was. So I am in Maryland and I went to Stafford Hospital in Virginia. And so with absolutely no traffic on 495, it's about like an hour and 15 to an hour 30 minutes from my house. But of course, there's always traffic on 495. So it could take me anywhere from 1.5 hours to 3 hours to get to my clinical site. And then again, 1.5 to 3 hours to come home. So that was honestly a nightmare, but that was the only bad thing about this clinical, how far it was. So now to talk about like the design of my clinical and just like my overall clinical experience. So like I mentioned, I was at Stafford Hospital and I'm so happy that I chose this hospital because I was on their LDRP unit. So I actually didn't know what LDRP was. I wrote it down so I won't forget. It's their labor, delivery, recovery, and postpartum unit. So the incredible thing about this unit, all hospitals are a little bit different. In some hospitals, they have the labor and delivery unit, and that is separate from their postpartum unit. And then in other hospitals like Stafford, they have an LDRP unit where it's kind of like 2 units in one. So on the same floor, on the same unit, we had women coming in that were actively in labor, getting ready to deliver their baby. And then on that same unit, that same floor, we also had postpartum. So we had couplets. So we had the mother and the baby that were in recovery. So the reason why I liked it this way is because at least our school policy is that when you go to a hospital and you're on a unit, you're not supposed to just be going all up and down anywhere in the hospital. And so if I was at a hospital where the 2 units were separate, I would only be getting experience in the labor and delivery unit, or I would only be getting experience in the postpartum unit. So since it was kind of like 2 in 1 at this hospital, I was able to spend time shadowing labor and delivery nurse. So I was able to take care of a woman that was actively in labor. I was also able to take care of a couplet, so a mother baby after delivery. And I was also able to spend a little bit of time in the NICU, just having the newborn as my patient and doing critical care. So I feel like my overall clinical experience during this clinical was incredible, and I got to do a little bit of everything and really see, just get a really quick glimpse of everything that fell underneath this umbrella of maternity. So now in terms of the layout of this actual clinical, at Chamberlain, maternal child nursing does require 48 clinical hours. Some classes require 48 clinical hours. Some classes require 96, I believe. So for a 48-hour clinical, it can be broken up in a couple of different ways. At least that's how Chamberlain does it. So some classes that require 48 clinical hours, some classes will have you doing 4 12-hour days. Other classes will have you doing 6 8-hour days. So for this clinical, I did 4 12-hour days of clinical. So I only went to the hospital 3 times, but each time I went to the hospital was 12 hours. And then on top of that, I of course had a sim day. For every class, you have to go to campus and spend a full day doing sim, like a simulated clinical session. So I had 4 clinical days, but I only spent 3 days in the hospital. I actually uploaded a video of me going to sim. I couldn't show like too much because I never want to like enter the realm of cheating, and I don't want to film other people that haven't consented to being filmed. But pretty much, if you want to check out a breakdown of my sim day, I detailed it pretty much in that video. So I did not go to the hospital one of my clinical days. I went to campus, and you can check out that video. For the other 3 days of clinical, I did go to the hospital. So for the layout, there were 4 to 5 students in my clinical rotation. So there were only 4 of us. So there was me, 2 other evening and weekend students. We had a day student that was in the same cohort, but she was just doing the program during the day. And then we had a 5th student that came to the hospital with us twice. She didn't come to our sim day, and she didn't go to the last day at the hospital because she was from a cohort ahead of us, and she had clinical hours that she had to make up. So for half of our clinical, there were 5 of us, but really there were only 4 of us, if that makes sense. And then we had our instructor. So it was essentially a 4-to-1 ratio, which honestly felt perfect. And each of us were kind of paired with a nurse. Really, we'd be assigned a patient, and then whichever nurse had that patient on their assignment sheet, they kind of determined what our day would look like. Some of the nurses really had us being very hands-on with our one patient that we were assigned, and then other nurses had us being hands-on with that one patient, but then we would, be able to shadow the nurse as they tended to their other patients. To be honest, I did mostly work with postpartum, so I did have a couplet. A couplet is where you have a mother and a baby, so they're actually 2 patients. I feel like it's kind of confusing unless you take in maternity, unless you're familiar with it, because it feels like the mom is your patient and then the baby is just there. But no, the baby, as small and as tiny as they are, that is a human that you have to do assessments for, you have to do medication administration for, you have to chart for. So it's called a couplet, and so it really is 2 patients that you have to a room once it's postpartum. And that's only if the mom has 1 baby. If she has twins, then you of course have the 3 patients. And then if you are in labor and delivery, so before the mother delivers, then you just have the 1 patient. Or if you're in the NICU, then of course you have the baby itself is the 1 patient, and the mother is not your patient. You're only taking care of the baby. So I did spend most of my time working with postpartum couplets, the mother and the baby. And I did have a day where I got to do labor and delivery, and I spent an entire day in the NICU, which was really a cool experience. So for clinical, we do of course have work to do other than just getting to be in the hospital and doing clinical. Every clinical day we had an IS-bar or an S-bar that we had to complete. If we were working with mother baby, we had to do an S-bar for the couplet, so for the 2 patients. If we were just working with the mom, we had to do it just for the mom, NICU, etc. So you do it for your patients, whoever or however many patients you have. So we had to do at least 1 S-bar for every clinical day that we had. We had to do a reflection every week. So we either wrote or typed up a reflection that we had to submit. And then we did have this 10-page documentation that we had to do. In the past, I've only had to do one of these 10 to 12-page packets, these documentation packets, for the entire session. You don't have to do them every week. But for this course, I had to do two. I had to do one for the mother, so one 10-page documentation for the mother by the end of the session, and then I had to do one full 10-page documentation for the baby by the end of the session. So in total, it was 20 pages that I had to do, but it was not due every week. And then we also had something called a CLE, which is a clinical learning activity. Even though it's called CLE, really it should be CLA, but I don't know. There's so many acronyms in nursing school. But we had to do this packet, and so with this separate packet, this is an 8-page document that you work with your professor to do. So it's like skills check off. Your professor checks off if they've seen you administer medication, if they've seen you do like cath care, just any nursing skill, they see you do an assessment, they have to check it off and document how well you did it, whether or not you need improvement. You have like a midterm evaluation, and then you have a final evaluation where your professor is writing in this packet. And then at the end of the session, you have to submit that. So there is quite a bit of documentation that has to be done in any clinical, and so maternity is no different. You have all of your regular documentation that you have to do, but you have an extra 10-page packet that you also have to submit. And I don't know if that's just my professor, I don't know if that's just my campus, so I don't know if everybody will have to do that, because it seemed like they were like conflicting instructions, but I did 2 of those 10-page documentations. Oh, and I forgot to mention the way that the class was set up. So I only had to go to clinical 4 weeks. Of course, it's an 8-week class. The way that we did it, in some classes you'll have like an A and B schedule, where the even weeks, half of the class will go to the hospital, and then the odd weeks, the other half of the class will go. And if it's your week off, you're just home and you don't have to worry about going. The way that this class was set up was half of our class that was going to this hospital, they went in weeks 1 through 4. My half of the class went in weeks 5 through 8. So weeks 1 through 4, I was just chilling at home. I didn't have to worry about clinical. I didn't have to do any documentation or anything like that. And then once I hit week 5, that's when I started my clinical rotation, and I had to go every week and do the documentation and submit that every week. So a typical day with this clinical was that, just like any other clinical starts at 7, but you're supposed to be there no later than 6:45. So I'd get to the hospital around 6:30, 6:45. We'd all meet in the lobby, so my professor and the other students, and we would go up to the unit together. So in the lobby, my professor, I guess, would get there early. She was always the first one there. And so she would give us our assignments. So she would let us know the room number of our patient and the nurse that's assigned to that room. And then we would all go up on the unit together. We would put our stuff down in the break room. We'd, put everything we didn't need, our lunches away, our bags away, and we would just take out our S-bar, our pens, our clipboards, our pen light, our stethoscope, anything that we needed on the unit for patient care. We would take that with us. We wouldn't leave it in the break room, of course. And then we'd go out to the unit at the nurse's station. And so that is when we would meet our nurse. So of course it would be shift change. So we would get to see the nurses that were leaving, and we'd get to see the new nurses, or the day shift nurses, as they were coming in. That is when we would kind of get to meet our nurse, be introduced to our nurse. That's when our nurse would tell us like the name of our patient, and then we would kind of follow our nurse and listen as they received report from the evening nurse. So while the nurse that we were kind of paired with received report, we would also be in the background listening, and we would be writing in our S-bar, or we would be documenting about the patient as if we were receiving report too. And then from there, it just depends on each nurse's style. So I was really fortunate. I got paired with nothing but nice, friendly nurses that wanted me to be hands-on. So even though I had one patient that I was assigned to, every week I was kind of able to follow my nurse with all of their other patients. I was only assigned the female nurses, so I was able to follow my nurse with all of her other patients, and I was able to do documentation on all of her patients. And so we would go room to room, receive report outside of the room, And then we would go in, we would greet our patients, we'd meet our patients. I would introduce myself as I always say I'm the student nurse, and I will be assisting with providing care today. My nurse would introduce herself. She'd write her name up on the board. She'd ask if the patient needed any questions. And then while she was there, she wouldn't do an assessment on the patient or on the baby if we had a couplet, but she would just kind of look in the room, see if there was family in there, introduce herself to the family, record any names. So it was kind of like she was doing an environmental assessment, so assessing the room, assessing the relationships of the patient and the family support that the patient had. And so we'd go room to room doing that. And once the patients were fully transferred over to me and the nurse I was shadowing, then we would go to the nurse's station and she would look up documentation from the night before. So the vital signs and the status of all the patients. She would review all of the physician's orders, all of the medication orders in the MAR, and we would just kind of get our bearings and map out our day. Of course, like I said, every nurse is different and their process is a little bit different, but overall, this is pretty much how the day starts. You get report, you look and make sure your patients are okay, you check out the room, you meet the family, you introduce yourself, and then go back to the nurse's station and actually look in the chart to get more information and see what time medications need to be administered, if any labs need to be done, so that we can kind of map out our day, map out which patients we need to be checking in on more frequently, which patients we should be seeing first. And so then from there, we would just go room to room doing care. Cluster care is a big thing with any patient, but especially when you are dealing with newborns. So cluster care, for example, is, say that you have an assessment due at 9 and maybe you have a medication that should be administered at 9:15 and maybe something else that should be done at 9:30. Instead of going into the patient's room every 15 minutes and bothering them, especially when it's a baby who is just tired and hungry and wants to be left alone for the most part, you don't want to be going in every 15 minutes right when the baby's falling asleep. You have to wake up the baby and undress the baby and poke and prod the baby. So instead we do cluster care. So maybe at 9:15, you'll go into the patient's room once and you will do the assessment, you will administer the medication, and you will do anything else that would be done around that time instead of continuously going in and bothering the mother baby. So that's why it's super important to map out the day at the beginning of the shift after getting a report, because it is important to know who's getting medication at what time, who needs an assessment at one time. That way you can kind of plan out your clustered care. So yeah, this was my first time, of course, doing an assessment on a newborn. I loved it. I learned so much during this clinical. I feel like in class, we did go over how to do assessments on newborns, but I feel like I retained more information on how to do an assessment on a mother who just gave birth. So I really got to get hands-on experience when I was in the hospital for the newborn. And they're so tiny and so cute, and I honestly just fell in love with them. So first, of course, we would assess the mother. The assessment would be a little bit different depending on if it was a vaginal delivery versus a cesarean section. Of course, if there is a C-section, there is a wound and wound care that you have to do versus a vaginal delivery. I think because cesareans are so common, people often forget that it is surgery. It's not just childbirth. Of course, it is childbirth, but it's also a major surgery that does require pretty extensive recovery, and it's a lot that your body goes through. And so wound care, checking on the wound, keeping that area clean is extremely important to prevent infection. And so that was a big thing. So doing skin assessments were really important. And then on the baby, of course, the initial assessment is done at the bedside right after the baby is born, but you have to continuously do assessments. So of course, just like any other human, we have to check blood pressure. We have to take the temperature. Depending on what's going on with the baby, you have to prick its little foot for glucose levels. You have to do skin assessment. So if you notice any birthmarks, any scarring on the baby, you have to, of course, document that. It's important to reposition the baby. With babies, we need to be changing their diapers. For the male babies, circumcisions are pretty common. I saw a lot of circumcisions going on at the hospital. So you have to make sure that you are caring for the perineal area of the baby after they have a circumcision. You have to keep it clean, you have to keep it moist, you have to make sure that it's clotting and that the baby is not just bleeding out. So there is extra care for both the mother and baby depending on what happened during childbirth and what happened right after childbirth. And so after we would see all of our patients, do our assessments, provide care, we'd go back to the nurse's station and I would chart with my nurse and we would have a lunch break. We went to the cafeteria, we all ate together, and then we'd head back up on the unit and I would kind of get like a little mini report from my nurse on what I missed while I was at lunch, which is exactly how it's going to be when you are at the hospital working as a real nurse. Whenever you leave for a bit to go to lunch or even to go to the bathroom, you need to come back and whatever nurse was covering for you, you'll need to ask them if there are any status changes in your patient while you were gone. And so nurses do cover for each other. So the same way that my nurse that I was assigned with was kind of covering for me while I was at lunch, when I got back, I had to get my patient transferred back over to me, because just because you go to lunch doesn't mean that the patient just doesn't receive care. You have to transfer that over to somebody. So then after the day was over, usually we'd get like another little break in the afternoon, like a little 10-minute break or so. My professor would just kind of pull us one by one. Lunch we all went to together, but for our afternoon break, we just get 10 minutes and my professor was like, hey, if you need a snack, if you need to take a break, just go to the break room for a few minutes and then come back out on the floor, but communicate that with your nurse. Anytime you leave the area, you need to communicate that with your nurse, because somebody needs to know that your patient needs to be cared for while you're gone. And so we'd come back on the unit, finish up our day, and then around 7:30, we would gather our stuff from the break room, go down to the lobby, and we would do our post-conference. I actually really enjoyed this post-conference. We have it at the end of every clinical for every class. But you pretty much go one by one and talk about like what you learned, what you got to do. Our professor would kind of evaluate us all as a group. And it was just kind of like a nice debriefing before we got to go home. And so for this clinical, I loved it because I got to do and see so much. And I liked hearing what other people got to do and see. So it was just kind of really fun to just kind of like share birth stories and things like that. And then in terms of what I got to do and see, of course, a lot of assessments, medication administration. On top of that, I saw a vaginal delivery, which was extremely exciting because I know, or at least I've heard, people go to the hospital. Sometimes if you're lucky, you'll see birth. Other times, you know, not everybody gets to see birth while they're doing maternity. I was really fortunate that a mother allowed students to come in and see the birthing process. So I saw literally everything. I saw the crowning. We had like a front row seat. We were in the corner, like literally it was me and a couple other students. We were in the corner with like our hands tucked in front of us, trying to stay out of everybody's way. But I was able to, the angle that I was at, I was able to see literally everything. And I was able to, more importantly, watch the process of the baby being born, things being transferred over from the nurse to the physician. So the physician actually coming in and delivering the baby, taking out the umbilical cord, the placenta being delivered, and just literally I saw everything. And it was honestly very beautiful. It was incredible. I was greedy and I really wanted to see a cesarean section birth. I didn't get to see one, although some of my classmates did, so I think we all saw some form of childbirth, which was really cool. I did not see circumcision. I think all of my classmates did except for me. I was just kind of running around. But when I was in the NICU, I got to care for babies right after they were circumcised. So again, I learned a lot I did not know. After a baby is circumcised, at least at this hospital that I worked at, they are then taken directly to the NICU and they stay in the NICU for an hour, and every 15 minutes, a nurse will check their perineal area to make sure that there's not excessive bleeding, there's not any abnormalities that are going on at the site. And so of course, while that's happening, you get to hold the baby, you get to change the diapers, but you pretty much, you just get to assess and care for the baby in that hour. And so the day I was at the NICU, so many babies, like baby boys, I guess, were in the hospital, because I swear we had at least 5 babies that came in that required, like, they call them circ checks, so circumcision checks. So it's every 15 minutes, but I swear there were at least 5 baby boys that came in throughout the day, and I was obsessed with all of them. And so the first one, my nurse did the circ checks, and then every circ check after that, she allowed me to do it while she watched over me. So I was like, yep, looks good, it looks okay, everything looks normal. I changed the diapers, I put on Vaseline and provided care. And so she observed me and monitored me just to make sure everything was being done correctly. So I got to be really hands-on, which was very cool. I got to see an epidural, which I've heard the needle is huge. The needle is huge. It was intense. I got to see a blood patch. So there are some complications that can happen with an epidural, and it's not very common, but when it does happen, there are interventions that are in place that can help to alleviate those symptoms. They're not long-term symptoms. So I got to see a blood patch being done, which the same needle for the epidural is used. So I got to see that and see the process, which was really cool. I got to, of course, see pharmacological methods that are used to induce labor, to reduce pain postpartum or before birth. And then I also got to see non-pharmacological measures. So therapeutic measures like dimming the lights, using essential oils, playing music, things like that. So it was really cool. It was overall a really good experience, and I learned a lot. Now that I have taken maternity, I can be completely honest, my view of childbirth has changed so much. So for those of y'all that don't know, I mean, my age isn't super relevant, but I'm 29. I'm turning 30 in November. I'm married. I've been married for a few years, and we do one day want to have a family. That day is approaching sooner than and I'd like to admit. I always said like maybe around 30-ish when I'm done with nursing school. And so I'm finishing nursing school in a few months. I'm turning 30 in a few weeks. So that is, you know, approaching. But I always had this view of how I would want my childbirth to be and my view of what childbirth was. And I will be completely honest, I didn't realize how uneducated I was about the birthing process until I took maternal child nursing. I learned so much in this class, and that's why I think taking classes like this is good, and that's why I think being in clinical is good, because of course it's really good for the profession to know which specialty you should work in, to know what it's like at the hospital. But I feel like classes like this, or classes like peds or what have you, certain classes can also change your outlook on things in your personal life and personal decisions. So for example, I always thought that I wanted to do, like, I always told myself, if I have a super healthy pregnancy and if I get the okay from a physician, I would like to do like an at-home water birth, and I'd like to have a doula. And I did not know some hospitals, at least in my area, will actually work with you. So if you want to go to the hospital and not use any medication, if you want to take like a little pool and do a water birth at the hospital and bring your doula, some hospitals, at least in my area, will actually accommodate that. There are also other alternatives like birthing centers and things like that. But I feel like people, or at least I had this perception of, if I go to the hospital, I have to be in a hospital bed, I have to do their processes. But you really can work with the hospital and work with healthcare professionals at the hospital to create a birthing plan that fits what you want to do. I still think at-home births are beautiful. I know a lot of women do it and they turn out perfectly fine. For me, the reason why I'm now like, I'm definitely gonna go to the hospital if I'm ever blessed to have a child, is because taking this class, I've learned of all of the different things that can go wrong during childbirth. Literally anything can happen. Even the most meticulously planned pregnancy and the most meticulous birthing plan can go awry in the moment. And that's even if you have a perfectly healthy fetus, that's if you have a perfectly healthy baby, that's if you've been perfectly healthy your whole pregnancy. Anything could happen. And so I think for me, I'd rather be at the hospital. That way, if anything were to happen, I'm right there and we can start interventions immediately. Every second counts. If you are losing blood, if you're losing oxygen, if your baby's losing oxygen, And so once I learned of all of the different things that could happen during childbirth, I was like, I'm just gonna go to the hospital. Another really big thing I always told myself was I wanted to decide once I'm pregnant and once I'm like closer to actually delivering a baby, because I'm not even pregnant right now, but I always had this idea in my mind that I would not get an epidural unless like I just really felt like I needed it, I guess, in the moment. But now I think I'm going to do more research, but I think I'm going to plan to have an epidural. My interpretation, or what I always thought about epidurals, the reason why I didn't want one was because I thought that it would delay pregnancy. Like, I always heard that if you don't have an epidural, you can deliver your baby kind of super fast. If you do get an epidural, the second you get it, it just slows down the process and labor is extra long. And so that was the main reason why I was like, I don't want an epidural. I'd rather just deal with the pain and have the baby come out faster. Now that I've actually taken maternity and I've actually been in the hospital and I've seen labor and childbirth and postpartum, to me it doesn't really seem like there's much of a difference in terms of time. It seems like it makes more of a difference whether it's like your first child versus subsequent or later pregnancies. So the first pregnancy that you have, your labor is typically going to be longer than if you have a second, third, fourth baby, what have you. Just because this is your first time that your body's doing it, this is new for your body. So whether you get the epidural or not doesn't seem to really slow down the process, at least not as much as I thought it did. It really does not make much of a difference. And I've now seen labor with the epidural and without the epidural. I've heard women's stories, and to me it seems like with the epidural, a lot of women have said that it allowed them to be more present in the moment because they didn't feel as much going on. I've even had a couple women say they didn't feel a thing until after it wore off. Then of course they felt the pain after childbirth, but it really allowed them to be present in the moment. And to me, that's the most important thing. And also, yeah, I feel like it's cool to say that you delivered a baby without an epidural, but I feel like, you know, there's no award. Like, you don't get an award, you don't get a prize if you delivered your baby without an epidural. Like, nobody really cares. So I'm kind of like, from all of that, it doesn't, to me, I feel like it's just personal preference. And now that I have more information, I think my personal preference would probably be just to get an epidural. Another thing, I feel like now that I'm like dispelling all of the myths that I had, I just like, again, I didn't realize how much I didn't know, or I didn't realize how ignorant I was on the topic until taking maternity and actually being in the hospital and seeing these processes in person. But another thing was that I thought that C-sections, I'd always heard women say that the recovery is a lot, and the recovery is worse or more intense than a vaginal delivery. I think that that just depends person to person. There's so many different factors that factor into it, but my perception was that like, oh, like with a C-section, you could just, you know, have a C-section and kind of be asleep, and then you wake up and your baby is there. That is so wrong. And I don't know if I'm the only one that thought that. That's so wrong. For one thing, obviously you are numbed, you are medicated, you're fully awake for the process. And then it's a major surgery. Again, I feel like because it's become so much more common, and apparently physicians are trying to move away from C-sections unless it's absolutely necessary, because it is dangerous. You're at higher risk of infection. The recovery is very painful. It's a lot longer than if you have a vaginal delivery. It's not something that you're like, oh, this is an easy way to deliver a child, I'm going to do it that way. Like, that's could not be farther from the truth. The truth is, I don't think there's any easy way to deliver a child, and I don't think there's any painless way to deliver a child. It's just, there are different complications and different factors based on whichever route you go through to have a child. And also, there's nothing wrong with a C-section. This is not a misconception that I had, but I know that this was a misconception that some of my classmates had, and they said that taking maternity changed their opinion on it. I feel like in the past, vaginal deliveries were referred to as natural deliveries or natural birth, especially vaginal deliveries that were unmedicated, so without the epidural, were considered a natural childbirth, while cesareans or even vaginal deliveries with the epidural were not called natural childbirth. It's all natural childbirth. Like, childbirth is natural. It's all childbirth. It's just a different method of extracting the baby. So one way is not better than another. Again, it goes back to whether or not to get an epidural. Whether you, well, I don't want to be crass, but whether the baby comes out vaginally or whether it is extracted through a cesarean section, it's all childbirth. At the end of the day, all that matters is that you deliver safely. All that matters is that the mother is safe, alive, and okay and healthy at the end of the day, and that the baby has been delivered safe, healthy at the end of the day. You know, when the baby's 10 years old, no one's gonna get an award because they had a vaginal delivery over a cesarean. No one's gonna get an award because they didn't get an epidural, because they did get an epidural. All of these things are just personal choice, and at least in school and in the profession, I don't know about socially, but at least in the world of healthcare, I think we're kind of moving away from the notion that one is better or more noble than the other. Because unfortunately, there are a lot of scenarios, like I mentioned, anything can happen during childbirth, even if you have a super healthy pregnancy. It does happen, unfortunately, sometimes where people create their birthing plan, they say that they want to have a vaginal delivery, and maybe something happens right as the baby's about to come out. The baby could be breached, so the baby could be in the wrong position, the baby could start losing oxygen. Anything could happen where an emergency cesarean section needs to happen in order for the baby to come out safely and for the mother to be safe. And so I feel like when there's a stigma over C-sections or there's a stigma on medication, if you're somebody who plans to have a vaginal delivery, especially unmedicated, something happens and you need to save the baby's life to get a cesarean, the mother or the family should not then feel bad or guilty or ashamed because their birthing plan changed. Again, one isn't better than the other. As long as the baby comes out safely and healthy, that should be something to celebrate, not the way that the baby came out, in my opinion. So yeah, I learned a lot. I definitely think that this is a specialty I would love to go into. I fell in love with it. I don't like working with kids, so I liked peds. I loved my peds clinical instructor. I loved my experience. I loved my didactic professor. I loved everyone I got to work with in peds, but I was just like, I don't want to work with kids. And so with maternity, I knew I would like working with the moms, but I wasn't sure how I'd feel about the babies. I fell in love with the babies. I fell in love with this specialty. I would love to have the opportunity to go into this specialty. I got a text message. I would love the opportunity to go into this specialty after I graduate. I think right now my top choices are neck and neck between OB, and so that's everything under the umbrella of NICU, labor and delivery, and postpartum. So that is my top choice, tied with working in the ICU. And then my second choice, or my next choice, would be to work in the ER, because I did do a clinical rotation in the emergency department and I loved it. I loved how busy it was. I loved how chaotic it was. And so I think when I graduate, I think I've officially decided I'm going to apply to all three of those areas, with OB and ICU being my top choice, ER kind of being a backup, and then whoever takes me, I guess that's where I'll probably go. At least that's where my head is at right now. I do plan to do more research though on the birthing process and different birthing options. Like I said, I was really surprised to learn that you could do a more holistic childbirth. So if you want to deliver in water, if you want to have a doula, you want to have like calming music. Of course, you have to look at different hospitals. I'm not sure if every hospital does it, but I didn't think that any hospitals did it. I didn't even know that it was an option. So I feel like there's so much more that I want to do research on my own and to explore about the whole birthing process and all the different options before I actually start trying to have a baby. If, you know, by the grace of God, if I'm blessed with getting pregnant and blessed with having a baby, I want to do more research so I can know what my options are. And if you're somebody, even if you've already had a child, if you want to have more children, if you want to have children in the future, I would strongly encourage you to do research, because I feel like there are so many different options for birthing out there, and a lot of women don't know that you have options. You need to research your options, know what they are, so that you can advocate for yourself. Because I feel like, at least in the States, I live in the US, I feel like we're not really taught too much about healthcare and how to make informed healthcare decisions. Unfortunately, if you want to know what all of your options are with healthcare, especially for women, especially when it comes to childbirth, we have to do our own research. So I would implore you to do your own research so that you're able to deliver the way that you want to deliver, and to deliver in a safe environment, and to have as much control as you want to have. So that is it for this video. If you made it to the end, thank you guys so much for watching. Please like this video and subscribe to my channel. Otherwise, I will see you guys in my next video.